my name is Dr. Goldman. I'm an Associate Professor of Medicine at UCLA, and I'm very happy to welcome you to our discussion of small cell lung cancer. We will be discussing translating science, transforming practice, and making headway toward better outcomes in small cell lung cancer. It's my pleasure to introduce the rest of the faculty. Tiziana Leal is at the Winship Cancer Institute at Emory University, and Taufik Owonikoko is at the University of Pittsburgh Hillman Cancer Center. We would like to thank the Medical Learning Institute and PeerView, as well as AstraZeneca, for providing the educational grant for this webcast. There will be poll questions and an opportunity to ask questions to the faculty. Here are our disclosures. And if you'd like to get this in an on-demand version, please visit this website, and it is the same place you go for CME or MOC credit. Here's our agenda. We'll be talking about new treatment advances in the first-line therapy with immunotherapy and chemotherapy in small cell lung cancer. We'll be discussing how we apply this progress to clinical care, and then sharing our reflections. As we all know, small cell lung cancer has been a very challenging place for patient care and development in the recent decades. Platinum and etoposide was introduced about 50 years ago and is still the backbone of our therapy. Early response rates are high, but the duration of response is not what we would like to see. As we are trying to improve our long-term outcomes across cancer care, this is an area of serious need. We found that there are several barriers to therapy in lung cancer, and specifically in small cell lung cancer, some related to tobacco-related comorbidities. There can even be patient shame and other factors related to a history of tobacco use and the development of this cancer, as well as the challenges of treating a rapidly progressive cancer. In some areas, diagnosis often occurs in the hospital, and therapy sometimes needs to be delivered there in order to get the cancer and cancer symptoms under control. Also, I think we'd like to underscore the significant need for ongoing research. Thankfully, we now have some advances, and in order to carry those forward and continue to improve outcomes, something that's sorely needed, we need to focus on clinical trials. There has been real excitement across cancer care in general for immunotherapy, and what can we do to bring that to small cell lung cancer? Many, if not all of us, have seen this slide before regarding tumor mutation burden across tumors. And we can see, as we all know, that small cell lung cancer has a very disordered genome and should be an excellent target for immunotherapy. Thankfully, in the last couple of years, we've had some very meaningful and significant changes in our first-line therapy, and that's where we're going to begin our discussion with Dr. Leal discussing the Empower 133 trial.
Thank you, Dr. Goldman. We'll provide an overview of Empower 133. This is a study in the phase 3 setting that randomized patients to a PD-L1 inhibitor, atezolizumab in combination with platinum etoposide, followed by atezolizumab maintenance in the experimental arm. In the control arm, patients received the standard of care therapy with carboplatin etoposide and placebo. Patients were eligible with frontline untreated small cell lung cancer. They had to have good performance status and also treated asymptomatic brain mets. Here we see the stratification factors of sex, ECOG performance status, and brain mets, yes versus no. And this study had co-primary endpoints of overall survival and investigator-assessed progression-free survival. Key secondary endpoints included overall response rate, duration of response, and safety. And here are the results in terms of one of the primary endpoints of progression-free survival. This is, as we know, a positive study that met its primary endpoint of progression-free survival with the median progression-free survival of atezolizumab of 5.2 months. So modest improvement in progression-free survival. I think more meaningful is looking at the landmark analysis here at 12-month PFS of 12.6. versus 5.4 in the placebo arm. We also saw the overall survival improvement with the addition of atezolizumab to chemotherapy. And now with longer follow-up and a median follow-up of 22.9 months, we continue to see this sustained benefit of the addition of atezo to chemo with an 18-month overall survival of 34% versus 21%. And we've seen the 24-month overall survival updates also of 22% versus 16.8% in the control arm. So definitely an improvement. This led to the approval of this combination in the frontline setting, and this is our standard of care for patients with untreated extensive stage small cell lung cancer. So here are some of the safety results for IMpower 133. And I think the take-home message from this slide, and now as we treat patients with small cell lung cancer with this regimen, we see that this regimen is well tolerated. So the addition of immunotherapy did not seem to add any additional significant toxicity to this combination. And additionally, there have been quality of life studies done that show that the addition of immunotherapy in this regimen to chemo did not increase symptom burden for patients. As expected, there were more immune-related adverse events in the immunotherapy arm compared to the control arm. Looking here at the dose intensity was similar for both treatment groups. The median number of doses received for atezolizumab is 7 doses. Moving forward to some interesting data that has been presented, that was recently presented at ESMO, was a little bit more of talking about the small cell lung cancer subtypes. We know that there are four biologic subtypes that can be defined based on differential expression of transcription factors. And we have here the 4 subtypes. And basically, I'll kind of summarize the results of this study and kind of give you a little bit more about where we think this is going. So this study looked at gene expression analysis in long-term survivors from the IMpower 133 and associations between differential gene expression and these small cell lung cancer subtypes based on the RNA-seq data. I'd like to highlight, though, that this was done in a subset of patients in the IMpower 133 study. Only about 67% of the population of the study were able to have enough tissue to perform this RNA-seq data. But I think it's interesting to highlight some of the efforts in terms of biomarker development and trying to really identify subsets of patients that are really benefiting from the combination strategy of immunotherapy plus chemo. And just to kind of give you the overview of the results of this analysis, in both treatment arms, both in the atezo plus chemo and the control arm of chemotherapy plus placebo, the expression of genes related to cytotoxic T cells, B cells, and interferon signaling was enriched in patients who had tumors in the long-term survivors. Just to point out, there was a slightly higher number of long-term survivors in atezo plus chemo versus not, but both of the treatment arms had this expression in the long-term survivor subsets. And then looking here at the differential gene expression in long-term survivors versus not, single gene and gene expression signatures showed that the long-term survivors in both arms had elevated expression of markers of T effector and B cell infiltration and function compared to the non-long-term survivors. And then lastly, looking at these different subtypes, we've seen that there's a subtype called the small cell lung cancer I, the inflamed subtype. And I think it's interesting to point out that prior preclinical studies and other series have shown that this inflamed subtype seems to be the subgroup that appears to have the most benefit from the addition of immunotherapy to combination strategies. And here in this study, in this analysis, in the long-term survivors RNA-seq population, there was a similar distribution of small cell lung cancer gene expression subtypes in both treatment groups, and the inflamed subtype was enriched and accounted for 28% of the long-term survivors receiving atezolizumab and 32% of the long-term survivors in the placebo arm. So looking here in terms of enrichment of long-term survivors among the inflamed subtype associated with atezo, there were non-significant trends observed in this small cell lung cancer subtype, the inflamed subtype. In the atezo arm, 55% were long-term survivors, and in the placebo arm, 30% were long-term survivors. There was a higher percentage of the inflamed subset that were long-term survivors versus not in the atezo arm. The long-term survivors in the atezo arm were not limited to one specific subset, and there was benefit seen across all subtypes. So I think this is an interesting analysis, and I think we're kind of learning more and more about these biologic subtypes. And I think I'd like to have a discussion here with our panelists in terms of what is their take on this data, and do you see this ready for clinical practice, or is this something that we need to study prospectively in clinical trials to really roll it out to clinical practice?
I think, first of all, that was a great review, and thank you very much for taking us through that. I think it is obviously a great unmet need to be able to select our patients that may benefit or may not benefit from immunotherapy. I think it's been a very challenging area so far, and we'll talk in a second about Caspian. There were some similar efforts in Caspian, but to my eyes right now, we haven't figured this out. And I think we have some interesting leads that need further study. As you said, applying them prospectively in a confirmatory group really would make all the difference. At this point, I am a little disappointed in all of the markers that they don't really seem to be strong markers, strong associations with benefit or lack of benefit. Do you see it differently? How are you thinking about this?
Yeah, I do agree that these biomarker efforts using the Empower 133 data set is very encouraging, promising, taking us in the right direction. I don't think we are ready to start using this information to necessarily select patients in the clinic. They're hypothesis generating, albeit very strong hypothesis. So being able to prospectively test whether or not the inflamed subtype, however we define it, whether it's looking at the non-neuroendocrine subset as a whole, or using the RNA-seq analysis as was done in the published manuscript, could be brought into the clinical arena, I think remains to be seen. But I do feel that this data is very, very encouraging, and we have to move with it and make sure that we can validate this and hopefully bring it into regular clinical care for patients.
Maybe we'll move to the Caspian trial now. So the Caspian trial, in some ways similar, also looking at extensive stage small cell lung cancer, platinum etoposide alone or with immunotherapy, but there are some important differences. It is not a blinded study. It was open label. Perhaps the most interesting is that there was a durvalumab, a PD-L1 inhibitor plus EP arm, and then the durvalumab with tremelimumab, the CTLA-4 inhibitor, as a third arm. Some other differences as far as eligibility. Brain mets were allowed, treated or untreated, as long as they were asymptomatic. The EP alone arm went up to 6 cycles, so a little bit more of a robust comparator. There was specifically PCI was allowed in that EP arm. So to some degree trying to set up kind of a real world comparison about how patients might be treated. The PCI was optional, importantly. And then as well, the platinum could be carboplatin or cisplatin, perhaps less important in the American arena, but in Europe, cisplatin is certainly used more often than in the United States. Until recently, the data was the 2-year overall survival assessment, showing that the durvalumab arm did improve overall survival compared to the EP alone arm significantly. The differences, similar to the Empower 133 curves, the differences don't come on until about 6 months into therapy, but then the lines do diverge. It is encouraging to see that they don't come and cross again. The tremelimumab durvalumab arm performs in the end similarly to durvalumab, but not better, and statistically did not have a proven benefit over the EP alone arm. The important time points here at 18 and 24 months are are very encouraging, and then even more so at the recently updated to 3-year overall survival benefit, where about a little bit over a fifth of patients are alive at 2 years, and just under 20% are alive at 3 years. Clear distinction between the two curves, and really the appearance of a plateau, an improvement in the tail of the curve, which I have found very encouraging and exciting to talk to patients about. Really more of a meaningful chance of significant years of benefit compared to prior to very recent. The forest plot shows that all subgroups are benefiting carboplatin or cisplatin, younger or older, male and female. There is a smaller group of non-smokers, as would be expected, but they also seem to benefit from durvalumab. Brain mets or not, a separate analysis of liver mets also was not a negative predictor of benefit, which had been brought up in previous non-small cell trials. So all of these were encouraging. I'll just briefly look at the durva-tremi arm, which also shows this potential for long-term benefit. But in my mind, this trial likely has put to rest the role for CTLA-4 in small cell lung cancer, although that could be controversial. Here's the subgroup analysis. Not too much to learn beyond the durva combination arm. Here's some of the biomarker analysis. This is TMB, tumor mutation burden. It's been challenging to figure out what the appropriate cutoff of TMB is. So we looked at multiple cutoffs, and really none of them suggested a meaningful benefit to select patients based on TMB for immunotherapy, either for durvalumab or for durva-tremi. This is some of the long-term benefit analysis reported at the beginning of this year. Perhaps similarly to what Tiziana just presented, there are some long-term benefiters in both groups, but they're more commonly seen in the chemoimmunotherapy arm. About 3 times as many are in this long-term benefiting group. The toxicity, treatment exposure shows that in the, I'm not sure if we have it here, but in the chemotherapy arm, most patients got the 6 cycles of chemotherapy. There is some question if the reason that we didn't see quite as much benefit in the durva-tremi arm is due to toxicity limiting delivery of immunotherapy. That's not strongly suggested here, but it is a possibility. Toxicity generally very manageable with the addition of durvalumab. In particular, Tremi had some more toxicity above durva. Immune-related adverse events, as would be expected, were higher, but generally thyroid dysfunction and other very manageable toxicities. Here, looking at the serious adverse events, in general, not a highly concerning signal. So in summary, the 3-year data continues to show a real benefit to chemoimmunotherapy with durvalumab with EP. This is exciting and certainly a meaningful step forward for our patients. About 3 times as many patients were able to have this long-term survival with the addition of durva. So another opportunity to take a second to discuss if there's any patients that you might not give immunotherapy to, if there's certain situations that you're concerned about, or if there are other biomarkers that you've seen in follow-up analysis that you'd like to discuss.
So I will take this question to start out with. In terms of patients that are not eligible for immunotherapy, I think one of the clinical questions that always comes up is a lot of our patients that are coming in being diagnosed in the inpatient setting. And it's been more of a barrier in terms of being able to logistically start patients on cycle 1 with a combination of chemoimmunotherapy. Sometimes these patients are patients that are coming in with organ dysfunction or performance status issues, and they need to be clinically first optimized, and they receive their cycle 1 of chemotherapy in the hospital. And then a lot of times, due to logistical issues or cost issues, they end up getting cycle 2 with immunotherapy in combination with chemo. So not necessarily patients that aren't eligible, but that there is perhaps, a slight delay in starting because of these barriers that can occur in clinical practice. In terms of the patients that do not receive chemo IO or immunotherapy addition to the regimen, I would say, the subset of patients who are transplant patients, kidney transplants or lung transplants, those are patients that I think we really need more data in terms of the safety and efficacy in this subset of patients. And then there are the patients that have autoimmune conditions. I think increasingly we've seen safety and efficacy in that subset, but those patients that really require immunosuppressive therapy may not be candidates for the addition of immunotherapy. And then lastly, I think a population that has not been well studied is patients with perineoplastic syndromes, especially the neurologic perineoplastic syndromes that we see in patients with small cell lung cancer. So for those patients, if they are requiring additional immunosuppression or IVIG for neurologic perineoplastic syndrome, those are patients that I tend to not add immunotherapy given concerns for worsening of their neurologic perineoplastic syndrome.
Exactly. I treat all of those exactly the same way. Taufik, anything that you've selected in as you're thinking about this as interesting biomarkers or next steps in these chemoimmunotherapy development pathways?
Yeah, currently I don't have any validated biomarker that I go by, but what is reassuring is the fact that the Empower 133 and the Caspian data set actually almost look like mirror images of each other. So we really have very robust data showing that this strategy works, unfortunately only in a subset of our patients. And figuring out who those patients are before we give them the chemoimmunotherapy will be key. It is more from the value standpoint as opposed from toxicity standpoint, because as we saw in both studies, adding immunotherapy to chemotherapy really did not increase the toxicity rate, but the main value that we get by not treating everyone is that we want to give the drug to those who are more likely to benefit and not just give it to everyone willy-nilly. Having said that, I think Tiziana covered all of those challenging situations where one may not want to give immunotherapy. I would also say, at least in my own approach, if a patient is a candidate for chemotherapy, they're a candidate for chemoimmunotherapy. However, if a patient is not a candidate for chemotherapy, I will not just go ahead and give them immunotherapy alone in the hope that that's going to make a difference. So I think, as we've always prioritized a lot of our small cell patients, that we're a little bit more accepting of limited performance status to give chemotherapy. I will still use that same clinical decision making. But if somebody is really, really so far out in terms of poor performance status that I don't think they can even tolerate any chemotherapy, then I would not go out on a limb to say, oh, let's just try immunotherapy by itself. I think that is less likely to help the patient.
Yeah, I think that's such a good point, and we didn't get really into the history of the development, but unfortunately there were all these negative trials in second line and maintenance. So there does seem to be something important about the chemo immunotherapy combination and getting the immunotherapy started early on in therapy. And the one other thing to add, there has been some really hypothesis generating studies looking at potential biomarkers, including Hla analysis that was just reported from Caspian, showing about half the patients had Hla analysis that could be performed from the specimen sent in. And there was an association in the durvalumab arm alone with the specific Hla DQB1. So it's really post hoc and interesting and hard to explain why it would only be in the tremi arm, at least to my understanding. So I certainly wouldn't think that that's ready for prime time, but HLA analysis is really entering our understanding of immunotherapy and hopefully will provide some interesting understanding as we go forward. So now we'd like to discuss further the future directions and ongoing research. Taufik can take it from here.
Yeah, thank you again, Jonathan. I think we have some exciting approaches in this disease, and I'm very, very hopeful that we're going to have new ways of managing patients, both in the early frontline setting as well as later stages of the disease. So I think the question that we continue to ask ourselves is, can we actually select patients? Especially in the context of chemoimmunotherapy, can we identify the right patient for immunotherapy? And more importantly, can we identify the patient that we should not be giving immunotherapy for? One, so that we do not give them something that is just going to be sort of waste of resources because it doesn't benefit them, but also by looking at those patients in a different context to look at other strategies that might help them. And if you want to select patients at their appropriate biomarkers, we've already heard from Tiziana and Jonathan about this post hoc analysis from the Empower 133 and Caspian studies respectively, how some of these immune-related biomarkers could help us identify patients likely to benefit, and maybe even the HLA typing to help us identify those patients who might benefit disproportionately from the addition of anti-CTLA-4 to the chemoimmunotherapy backbone. But the data overall to date is still very, very early, immature, unvalidated, but they're leading us in the right direction. So if we look at PD-L1, which we know has become sort of standard in many tumor types, including non-small cell lung cancer, this has not performed well as a biomarker in small cell lung cancer. When we look at the Empower 133 data and the outcome based on the PD-L1 expression, we see that when we look at the intention to treat overall population, the hazard ratio of 0.76. And then going through various cut points for the biomarker selection, using different percentages of PD-L1 expression, whether 1% or 5%. What is clear about this is we actually do not find a cut point that specifically tells us in which group of patients we should or should not use atezolizumab along with chemotherapy. Because the importance of using a biomarker is not just to select patients to use. We also want to make sure that the biomarker is not misleading us from holding treatment for patients who are likely to benefit. So I would say at this point, PD-L1, based on this analysis from the Empower 133 trial, was not very helpful. Similar result was seen with the Caspian trial, looking at 1% expression on the immune cells or 1% expression on tumor cells as cut point. We could not come up with a subgroup of patients where one would be comfortable to only use or not to use durvalumab along with chemotherapy. So while PD-L1 expression has been useful in other tumor types, it's not very useful in small cell. The other challenge with using PD-L1 expression, as you can see from this breakdown, is the proportion of patients with tumor or immune cell expressing PD-L1 is actually very, very small. So even just the prevalence of PD-L1 expression already excluded almost 75% of our patients. And we do know that patients without PD-L1 expression could also benefit. And we're not going to go into all the vagaries and challenges of doing PD-L1 expression on small biopsy samples that may not necessarily represent the overall tumor burden in the patient. How about looking at blood-based assessment? If you want to run away from just using representative or non-representative biopsies, perhaps tumor mutational burden captured as study entry was done in Empower 133, which has also been shown to be predictive for benefit of atezolizumab in the oak and poplar non-small cell lung cancer trials. Could this be of help? There was pre-specified analysis using the cutoff of 10 and 16 mutations per megabasis that was established from the non-small cell lung cancer trial as potential threshold to identify patients who will likely benefit from the addition of atezo to chemotherapy in the IMpower133 trial. What does the results show is that both of these cut points, that is 10 or 16 mutations per megabasis, while you saw a trend towards stronger impact in terms of hazard ratio of overall survival, the higher the tumor mutational burden is, we still see that even in those with lower tumor mutational burden in the comparison, there was evidence to suggest that atezolizumab was still performing better. So we cannot use the tumor mutational burden from blood sample to exclude or to limit the use of atezolizumab along with chemotherapy in this patient population. Finally, while we do not have chemotherapy-based or immunotherapy-based biomarkers that could help us identify patients, there are other strategies being explored, either by bringing new modalities of treatment into this chemoimmunotherapy backbone, or bringing new immunotherapy agents as well as targeted therapies into the early stages of small cell lung cancer, both extensive stage and limited stage disease. Now, quickly in the next few minutes, provide an overview of some of these ongoing randomized trials that potentially could lead to better outcomes in patients if they turn out to be positive strategies. One is the LU007 or the Raptor trial. This is building on the success that we've already noticed from the IMpower133 that adding atezolizumab to chemotherapy in the front line is useful, and this will be followed by atezolizumab maintenance. The question is, if we have patients with oligometastatic disease, no more than 5 sites of disease involvement, who did well at the end of their induction chemoimmunotherapy of 4 to 6 cycles, can we further improve the outcome for this patient by giving them external beam radiation therapy to sites, not more than 5 sites, and then allow them to continue on atezolizumab? So this trial is going to enroll 324 patients who have completed chemoimmunotherapy induction treatment and did not progress, and then randomize them 1-to-1 to continue just with atezolizumab per standard of care, or receive radiation treatment to up to 5 sites and then continue with atezolizumab maintenance. Stratification factors informed by previous experience include 1 to 3 sites versus more than 3 sites of disease involvement, and the quality of response at the end of the chemo induction treatment prior to randomization, and of course performance status, which we know is a major driver of survival in this disease. PCI use is optional, and this will be done during the time that the patient is getting the consolidation external beam radiation treatment if the investigator and treating physician so decide. A patient with complete response after induction therapy will not be allowed to enroll on this trial. The second is the Adriatric Trial, which is looking at the limited stage disease setting. And this is really a very large trial that is randomizing patients who have completed 4 cycles of chemo radiation plus PCI to then go on to receive durvalumab plus placebo, as we know from the Pacific trial, or durvalumab along with tremelimumab in the hope that double immunotherapy agent might do better, and then placebo arm will be the standard comparator arm. This study is fully enrolled. We are eagerly awaiting the result, and hopefully this will give us newer options for our patients with limited stage disease. We must remind ourselves, though, that the Stimuli trial tried the same strategy. Unfortunately, that was a negative trial, I think in part because of the dose of ipilimumab that was used that made it difficult to deliver the planned dose. And then the LU005 is another limited stage disease, which is trying to introduce chemoimmunotherapy very early in the course of the treatment with the radiation. So patient will be randomized to standard chemoradiation, whether BID or single daily fractionation per investigator decision, or the same regimen along with atezolizumab followed by atezolizumab maintenance for 1 year. This study is enrolling briskly. As of the last update, it has actually enrolled more than half of the target population of 506, and we hope that this study will be fully enrolled by the end of 2022. And then the Skyscraper 2 is a phase 3 study that is bringing a new immunotherapy drug into the potential armamentarium for treating patients. This is also building on the Empower 133 backbone. Plan to enroll 400 patients to be randomized 1-to-1 to receive the Empower 133 regimen of atezo, platinum, and etoposide for 4 cycles, or the same backbone along with tiragolumab, which is an anti-TIGIT antibody. TIGIT is one of the newer checkpoint inhibitors that have been recently described and that potentially could mediate additional resistance to chemoimmunotherapy. Our early studies in non-small cell lung cancer show that this strategy could be very, very promising, and we're very hopeful that at the end of this trial, we might have additional options of immunotherapy agents for treating patients with extensive stage small cell. Finally, this is the SWOG trial 1929, which is a randomized trial looking at those patients who are likely to benefit from PARP inhibition. We've already known from prior work in the relapse setting that SLFN11 could be a predictor of benefit from PARP inhibition. So this study will allow patients to complete their standard chemoimmunotherapy for 4 cycles. And during this time, they will be enrolled to undergo integral biomarker assessment for SLFN11 test expression. If the tumor expresses SLFN11, then those patients will be allowed to be randomized to atezolizumab maintenance alone or atezolizumab plus talazoparib, a PARP inhibitor that's already approved in breast cancer. The rationale here is to select those patients who are likely to benefit from talazoparib and treat them along with atezolizumab in the maintenance setting based on the preclinical finding that targeting PARP along with checkpoint blockade could be synergistic. This study is currently enrolling, and I will encourage all of our participants, if they have this study open at their sites, to consider helping to get this done and offer our patient newer strategies of treatment. And then some of the agents in the horizon that are still quite early in development, as well as established agents that have now been brought back in new packaging. So liposomal irinotecan is a better way to deliver irinotecan into the tumor microenvironment. This study, the Resilient trial, was a phase 2-3 trial. The phase 2 component was reported with encouraging response rate of 44% in the relapse setting. The study has now moved forward to compare liposomal irinotecan to topotecan in the second-line setting. The importance of this trial is this is actually a trial that is contemporary, where patients would have been exposed to immunotherapy before. So this could offer us a new contemporary option of salvage therapy in the second line. And then additional strategies to use the body's immune system to control small cell lung cancer growth is with the use of CAR or engineered T-cell product, as well as bispecific T-cell engaging antibodies to redirect immune cells into the tumor microenvironment. The most advanced of this strategy is with tarlatamab or AMG 757. This was tested in a phase 1 trial that enrolled patients with previously treated and progressing small cell lung cancer to receive tarlatamab as a single agent. As we see on the screen, this agent showed activity across several doses being tested, ranging from 0.03 to 100 milligrams of tarlatamab. Some toxicities were noted, mostly cytokine release syndrome, which is more of on-target, consistent with the expected mechanism of action of this drug. 44% of patients experienced some degree of cytokine release syndrome. Reassuringly, only 2% of these were grade 3 or higher. There was a case of grade 5 pneumonitis reported as DLT, as well as a grade 3 encephalopathy. But early efficacy signal is there that response rate of 20%, especially in patients treated at higher doses of 30%, is quite promising and encouraging that this could offer us additional options of treatment for patients. In those patients that responded, the median duration of response in this heavily pretreated population was 8.7 months. So there is more to be learned as this study continues. There are now also 2 or 3 other bispecific T-cell engaging antibody constructs being tested in small cell lung cancer, either alone or in combination with immunotherapy. So with that, I would open it up to my co-panelists to sort of get their own viewpoint on what they feel is very promising in the coming years, and especially also to highlight some of the innovative trials that they're doing at UCLA, at Emory, as well as here in Pittsburgh. Jonathan and Tiziana?
Well, I think you've highlighted really some very exciting work there. I think liposomal irinotecan, relatively simple, but a very encouraging signal there. And DLL3 targeting, maybe we can take it more successfully forward after the initial challenges there. At UCLA, I'm looking at also some PARP inhibitor work, as we and at Mass General have described. There is some synergy with low-dose cytotoxics. So we're giving temozolomide along with talazoparib, and a slightly different dosing, a little bit lower than Anifarago gave. And we're about to report, but we've met, it was a Simon 2 stage design. We met our initial, and now we've met our endpoint for response rate. So we're excited to try to move that forward from here. We also have another trial which I think combines a few of these ideas, putting into maintenance therapy after first line. So with atezolizumab, another PARP inhibitor, niraparib, also with a low dose temozolomide. And there's multiple potential synergies, including just PARP inhibitor with immunotherapy, PARP inhibitor with low dose chemotherapy, and obviously also immunotherapy with chemotherapy. So all of those different doublets within that triplet, I think, are potentially interesting. So that's a randomized phase 2 trial versus atezolizumab alone, which is accruing currently. And I'm very excited to see where we get with that. Tiziana, what are you excited about these days?
Right, I think this was a great overview. I think all of the strategies here that were outlined are very promising. Additional strategies, kind of thinking about the relapse setting, is combination strategies of where immune checkpoint blockade fits into the subset of patients who have benefit and now have evidence of progression of their disease, and also looking at the platinum sensitive population. So we're interested in combination of chemoimmunotherapy, exploring the relapse population that's platinum sensitive, and kind of in a more definitive way answer the question of, can we re-challenge with a platinum in the relapsed platinum sensitive population, and where does IO fit into that space? Another, I think, interesting target that I think is still being investigated in small cell is really looking at the anti-GD2 target. And so those are things that we're also interested in and further kind of investigating as well.
That's great. I think we have a lot to still learn about this disease, but there's never a uniform way by which patient will present. So I think we can also maybe, along with our participants in the audience, maybe use some case illustration to highlight some of the key considerations as we manage these patients. So Tiziana, you want to take us through this first case?
So here's our first case. This is a 72-year-old male who presented to the emergency room for worsening shortness of breath over the course of a month. He developed worsening shortness of breath with difficulty walking across the room, used to do yard work, and was really active until these recent rapidly developing symptoms, and has a 60-pack-year smoking history. He underwent further evaluation, including a CT scan that demonstrated a right lung mass, bulky mediastinal adenopathy. Liver metastasis were also observed on the CT. He had an MRI of the brain, which showed 2 brain mets. The biopsy was done of the liver, which showed small cell lung cancer. So let's take a moment to discuss what is the appropriate first-line treatment option for this patient, and what would you do first? Would you start with systemic therapy, or would you do radiation to brain mets? Tawfiq, I'm going to go with you.
Yeah, I think this is one of our, almost like a textbook presentation of what small cell is about. Majority of our patients will have extensive stage disease at presentation. They're symptomatic. But now with the new era of chemoimmunotherapy, I think we are beginning to have some of these options of what to do. Looking at this patient who is very symptomatic, we want to get the patient started on treatment as quickly as possible. Not so much from the mediastinal disease, because we know that this disease is both sensitive to radiation as well as to chemotherapy. So for me, if a patient can start systemic therapy very quickly, I expect them to respond and for symptoms to improve. So I'm not going to spend a lot of time trying to radiotherapy debulk the patient. So I would just go with systemic therapy. And either one of the Empower 133 or Caspian regimen would be appropriate. The question to answer here is the approach in the past had always been when there is known brain metastasis to treat that first before we initiate systemic therapy. The Caspian trial did show us that when we have asymptomatic small metastasis, we might be able to get away with starting with systemic therapy, monitoring those metastases down the road, and then treating them as appropriately. So in a patient like this with symptomatic chest disease and not symptomatic from the brain, I want to know how big those brain mets are. If they're less than 1 centimeter, then I will go ahead and start the patient on platinum-based doublet chemotherapy along with IO. If you want to be a purist in terms of where the data is, if I want to do that, then I will do the chemotherapy with durvalumab, because that is the trial that allowed for untreated brain metastasis. Then monitor the patient post chemotherapy, immunotherapy induction. If the brain metastasis remains stable or even responding, let's not forget, about 30% of brain metastasis will also respond to systemic therapy. I will just continue to monitor the patient going forward. Jonathan, what's your take?
Exactly as you said. I think it's really been freeing in a way to be able to just get on to systemic therapy. A lot is how you see the patient and trying to weigh neurologic symptoms versus systemic symptoms. But this sounds like all systemic symptoms, and we know that's where we want to get our therapy directed. In the past, kind of setting up whole brain radiation and all that entails could be a month, and at which point the patient may not be well enough for systemic therapy. So I've been very happy to start with systemic therapy. And the other thing that we've started to do more is to think about stereotactic radiation. It used to be something we never did, but now if it's a limited number of lesions, especially in this case where you're starting on systemic therapy, where you think you might get some CNS control, I've appreciated being able to put off whole brain radiation and all of the toxicity and decreased quality of life that entails. And perhaps we might get SRS in between cycle 1 and 2, for example. But a lot depends on the details, how big they are, edema, etc.
Can I bring something back to discussion? Tawfiq, you mentioned, and I appreciate your comment about the Caspian and the inclusion of patients with small untreated asymptomatic brain mets. Give us your take on which agents do you think are really the most active here in terms of brain mets in patients with small cell lung cancer, and at what point would you reimage and consider taking a pause or continue on with systemic therapy for patients in the presence of controlled brain mets with systemic therapy?
So which agent is really active in the brain? I think it's difficult to say that one or the other of the regimen is doing the work. We know before the advent of immunotherapy that chemotherapy did work in brain metastasis for small cell. We never proved it because we are always worried about that progressing before the patient will get benefit. So the approach had always been go with the radiation to the brain, whole brain, and then start systemic therapy. We also know from the earlier studies of immunotherapy alone that intracranial response is just as good as extracranial response in non-small cell lung cancer. And now we have prospective randomized trial in melanoma also showing that immunotherapy alone can actually control asymptomatic brain metastasis. So I would say that perhaps the combination of the two backbones, chemotherapy and immunotherapy, is also helping to control the disease in the brain. Now, in terms of what to do after you're done with the induction phase of the treatment, do you actually go ahead and treat that metastasis before you move forward with maintenance? If we want to learn as much from the trial as possible, the Caspian trial actually did not mandate treating the brain metastasis if it wasn't symptomatic. So my approach for those patients we have elected to start with systemic therapy is to just monitor and wait until either there's evidence of further progression or symptoms to treat the brain metastasis with radiation. If I do elect to monitor and not treat, the requirement then is that the patient should be able to have not just CT scan of the head, but adequate MRI staging at least once every 2 to 3 months to monitor those spots. So that has been my own approach, consistent with what was done on the study.
Great, thank you.
I think case 2, Jonathan can take us through this.
Sure. So in some ways a similar case with initial presentation, but no evidence of metastasis. This is a 68-year-old woman with a large smoking history who was found to have on screening actually a left lung mass with hilar adenopathy. PET-CT showed FDG uptake at the mass and lymph node, but no distant metastases, and biopsy confirmed small cell lung cancer. She was treated with cisplatin and etoposide and concurrent radiation with curative intent, followed by PCI. 8 months later, recurrence occurred in the mediastinal lymph nodes and bone metastases. This was biopsy confirmed, and patient maintains a good performance status. She also, I think, interestingly, makes a point of saying she insists on improving her quality of life. I think that's interesting, of course, very valid, and many patients do bring up this question. Tiziana, how do you approach a patient like this? How do you think about the treatment options, and specifically, how do you address her concerns about quality of life?
Right. I think this is, a really important thing to focus on. I think no matter what, I think this is a really good point that the patient is bringing up. But I think we should focus on quality of life no matter what in all of our patients who present with something as serious as advanced small cell lung cancer. But in the case of this patient, I think, first of all, addressing what does she mean about quality of life? What does that mean to her? What are her goals, and what are the things that she hopes to accomplish? And then trying to set up a good supportive situation within our multidisciplinary team of things that we can offer her beyond, systemic treatment to control her disease, which I would argue can also help improve her quality of life. As we were talking about before, there has been data with Empower 133 looking at whether the addition of immunotherapy to chemotherapy affected quality of life in a negative way, and the answer was no. And a lot of times with our patients who have small cell lung cancer, they have high burden of disease, high burden of symptoms, and the chemotherapy, which can work quickly, can actually relieve some of these symptoms and improve their quality of life. But certainly beyond that, it may be that getting the multi-D approach with nutrition and social worker and psychology and other things that can help the patient sort of address some of the symptoms that worry her about quality of life. Now, for this patient, because she had recurrence of her disease 8 months after completing chemo with a platinum etoposide, I would define this patient as having platinum-sensitive disease using sort of the clinical cutoff of 6 months. Sometimes studies use a shorter interval, but I think clinically in general, 6 months is a good benchmark to say that the patient has platinum-sensitive disease, and this patient would be based on good performance status, and perhaps here without knowing comorbidities that would not preclude her from getting it, I would do a platinum etoposide combination. And I would use immunotherapy here since this patient is immunotherapy naive. And we've seen that IO monotherapy really in the second or third line setting has not been as successful as we had hoped it would be. So this patient would be somebody that I would offer and have a discussion about carboplatin etoposide in combination with immunotherapy.
Taufik, anything you would add?
I think Tiziana really highlighted the importance of quality of life. And, it's however the patient defines it. But oftentimes as clinicians, when we hear that, especially some of our colleagues who are not necessarily practicing clinical oncologists, they might take that to mean that the patient doesn't want treatment or doesn't want anything that would impact their quality of life at all. But in this case, especially in small cell, where we know that with disease progression, this is associated with a lot of symptoms. Actually, treating this patient is a good way to help them maintain their quality of life for as long as possible. And one thing I would add here is this is actually the type of patient where we want to encourage, our experts in palliative care to be part of the treatment plan for this patient as early in the course of the treatment as possible so that they can help co-manage whatever symptoms would arise and help this patient maintain their quality of life for as long as possible.
I agree. I think there still is in the popular culture this idea that there's a trade-off between living longer and quality of life. But with many cancers, and perhaps small cell lung cancer is early line small cell lung cancer is one of the best examples. Quality of life and effective treatment go hand in hand. We have one more case that I'll send it back to Taufik for.
So this is something that's a little bit more complicated than the straightforward ones we've had, and reflect now what we are facing in the clinic. Mr. B, 65-year-old male, presented with shortness of breath. X-ray showed a lung mass. CT scan confirmed the lung mass along with mediastinal adenopathy and liver metastasis. Multiple brain metastasis on brain MRI. As a previously healthy patient, now presenting with dyspnea and cough that has progressed over months. The patient is now here to see us. And the question is, in the presence of multiple small CNS metastases, liver metastasis, mediastinal adenopathy, what treatment should we recommend for this patient to help get them back on their feet? As we've already discussed exhaustively about the opportunity that we now have to be able to hold off brain-directed therapy when it is asymptomatic, small, and limited number, this patient was treated with chemoimmunotherapy. Did well. The cough and the dyspnea resolved within the first 2 cycles. He went on to complete 4 cycles of chemoimmunotherapy, at the end of which had whole brain radiation treatment, given the multiple brain metastases, some of which actually progressed slightly after induction chemotherapy. And then he continued with maintenance immunotherapy on a monthly schedule. Unfortunately, at some point during the maintenance immunotherapy phase, while he was still having good response, he reported that his dyspnea is coming back and was noted to be somewhat hypoxic in the clinic, raising several possibilities. Could this be recurrence of the disease? As we know, a lot of these patients can progress within months of finishing treatment. But this is the scan that was obtained following the patient's concern, showing some newly developing ground glass changes that are non-nodular, diffuse, and not related to the primary site of disease for which the patient was treated before. And as can be noted, there really no evidence for recurrent mediastinal adenopathy. So all of this will suggest some sort of treatment-related toxicity. And in the context of immunotherapy, I think all of us will immediately think of immune-related pneumonitis. So we know that immune-related adverse events, when it comes to the use of immunotherapy, can affect any organ system. And the best way to manage this is to anticipate it, prepare our patient for likely symptoms, but more importantly, to let the patient know that while the disease may start primarily in the chest, and perhaps in some may be just limited to the chest and a small amount of disease outside the chest, toxicity from immunotherapy could affect any organ system in the body, from head to toe, as we say. It's actually likely that if you're going to see anything, the most common organ affected by immune-related adverse events is skin and endocrine system. But respiratory system is the one that we worry about because a lot of our patients with small cell are heavy smokers with already compromised pulmonary reserve. So being able to detect this very early, instituting treatment appropriately, and then monitoring for response, and then deciding whether or not to re-challenge the patient with immunotherapy is key. And I will hand it over to Jonathan to guide us through some of the audience participant questions that come in during this presentation.
So it's been such a great discussion. We've actually covered a lot of these issues already. It's always a pleasure to speak with both of you. I think for the sake of time, let's go through quickly and just on these topics kind of go around and see what everyone's thoughts are. So we discussed some of the changes in radiation. And I'm interested in knowing, do you use PCI for limited stage, extensive stage, or consolidative chest radiation? Tiziana, how do you advise patients for those radiation questions?
Right. I think the PCI for extensive stage has really been used less and less in clinical practice. And I think when you look at the Empower and when you look even at the Caspian study in terms of the standard of care patients that received PCI, you see that those numbers are going down. And that's mainly because there was a phase 3 Japanese trial that really showed that there wasn't necessarily a benefit for PCI in extensive stage if you could monitor the brain, which requires active brain MRI surveillance, as Tawfiq had pointed out before, and then sort of intervening early before the patients have neurologic symptoms. So I think the PCI for extensive stage is something that has declined in terms of numbers that we use, but there are ongoing studies to really answer that question. And I think until that study is completed, I do tend to use PCI for limited stage disease in the curative setting. The consolidation radiation question, I think, is also a very important one, especially in the context of what we've seen, that perhaps radiation and immunotherapy can synergize. In both the Caspian and Empower 133, consolidation radiation to the chest was not permitted. So we don't have that answer from a clinical trial standpoint in a phase 3 setting. So I do try to really individualize that approach for consolidation radiation to those patients that I really think will benefit from the use. Let's say it's somebody who's had a great response outside of the chest, has some residual disease in the chest, and presented very symptomatic with bulky central disease, that I'm worried that they may have, progression of their disease at that site early on, because we know that the PFS is about 6 months with these combinations.
Tawfiq?
Yeah, similar approach. Generally don't recommend PCI for extensive stage disease. I encourage my patient to talk to the radiation oncology as well. Limited stage, I still do if they had good response, and I don't use consolidation chest radiation at this point in the absence of active progressing disease.
I maybe in some ways a little bit in the middle there. We've stopped using it for extensive stage, and actually unlikely to use it for limited stage as well. The data is so old at this point, all CT based, that I've seen such trouble for patients that may be cured of their small cell, but limited function because of brain radiation toxicity. And then consolidation radiation, exactly those cases that Tiziana was talking about, the ones that I'm worried really could develop into SVC syndrome or airway compromise if there's rapid growth. We've looked at radiation in those cases. The next question that I'd like to ask is really just a theoretical question, hard to be sure, but very interesting why the maintenance and second-line IO trials failed, whereas these two practice-changing phase 1 first-line trials of chemoimmunotherapy showed a benefit of immunotherapy, and at the same time, that benefit doesn't show up until the maintenance phase of therapy. It's something of a conundrum. Tawfiq, how do you put it put those facts all together?
Yeah, I think what these studies are telling us is that you need some degree of cytotoxic chemotherapy in the mix to get some real benefit from immunotherapy in this disease. As I alluded to while discussing the PD-L1 expression, only a small proportion of our patients are likely to have the inflamed or immunotherapy susceptible disease. So when we go into unselected patient population and we're using immunotherapy alone, we may actually be missing out on the potential benefit in the small subset. So I think the maintenance trial, the Checkmate 451, failed in part because there was a delay between the time patients were getting chemotherapy and when they went on the immunotherapy. Secondly, was the regimen was somewhat toxic, could not be delivered. And then when you look at the Checkmate 331 of topotecan versus nivolumab, that also did not show benefit. Part of that could be one, how we define benefit. If we go by our traditional, hazard ratio for overall survival based on the median estimate, we may actually be looking at the wrong endpoint. So if you follow that trial out, which is post-hoc analysis, you could see some tail to the curve in those patients treated with nivolumab. So perhaps better study design, but more importantly, finding the right biomarker to select patients who are likely to benefit could have helped showed impact of those strategies.
Tiziana, any thoughts?
I completely agree. I think, another just point is maybe lack of efficacy really in that setting. You've got a very refractory population. And I think we're seeing, even with the small cell lung cancer subtypes, that even within certain subtypes over time with treatment, there appears to be some migration to different subtypes. And so this resistance, this heterogeneity, makes it very difficult to have an agent, in later lines of therapy be successful in all comers. So again, I think it's getting back to the biomarker strategy and really identifying subsets more likely to benefit from one strategy or another, versus doing trials for all comers, which are unlikely to be successful in a very refractory population.
Great. It's really been a real pleasure to speak with both of you and get your thoughts. Why don't we just go around the circle and see if there's any concluding thoughts. Tiziana, what do you think?
Yeah, I think that we've made some progress in small cell lung cancer. I think chemo IO is here to stay in the front line. Certainly biomarker development is key, and I'm really interested in seeing a little bit more of the small cell lung cancer subtypes and prospective trials to see if that's really going to pan out and help us differentiate therapies that really benefit one group versus another.
And Taufik?
I do agree with all of that comment. I also look forward to the ongoing trials, especially in the limited stage disease. I think it's time for us to have something new for that population of patients. And I would add, it's really quite nice to be able to come to patients now and say, there is a new focus on small cell lung cancer. What I find talking to patients is so meaningful is not the month improvement in median overall survival, but the real chance of longer term survival with quality of life that we can hope to achieve on the new therapies. In case you'd like to review again on demand, here is the link. You can download slides, watch the replay, and receive CME and MOC credit. Thank you very much. It's been a pleasure to speak with you all.